Hey Steph, do you have the report in front of you? I just
I
need to,
can.
I'm just looking up the case number and I'm like, it's blinking right now. I think it's 1233,
Um,
but it might be, oh, it's because I haven't added an apostrophe. That might be why. Yep, I got it. I found it. I just
oh,
had it. I
great.
typed in an extra or typed in an apostrophe somewhere, so that was why I wasn't finding it. And then the other case is going to need to be looked up by. Cannoli, no one wants you to contribute. No one likes you. No one likes the cute little cannoli. Okay, I'll stop. I can't help it. She's so cute.
We had a 6-week-old and a 3-month-old puppy this morning.
For kidney stuff?
Yeah, both are leaky.
Mm,
Little 1 kilo, 6-week Havanese puppy.
I really want a puppy. What's my password? And you said you have a presentation. The hard thing is that the
Did.
slides are all kind of on different things. Might be just easier for me to open up the static images. I can have at least like one of the slides open. But you know how like it's just the way it doesn't matter, but it's not as easy to flip back and forth through like the kidney biopsy stuff that we normally do.
Right.
Also, I haven't seen you in person since you become a board certified nephrourologist.
Technically, I haven't submitted everything yet.
Oh, yeah, I don't think a lot of people have. I think that's still part of it, right? Like, yes, you still have to submit like that you did all the work.
I've been told repeatedly that it's just me and one other person who haven't submitted the necessary documents yet. The other person got it. Oh, it's just me.
Oh, well then you need to get your act together, doctor.
Yeah. Yeah. It did take me like an extra year and a half to get my medicine certification for not dissimilar reasons.
I mean, you are doing a lot of work,
I
so
am
I
going
can
to do it. I
understand
have
that
all the
sometimes.
signatures now. I just have the case log left. It's done, obviously. I just have to organize it.
I mean, as we're getting this started, I do think, and I know I can hear JD's voice in the back. But like doing the and Mary's on here as well, but doing this like affiliate member thing uh is like I know that Larry and everybody wants us to have this affiliate uh pathway, but like I'm like I could either publish papers or I can work on this, like taking all of the academic requirements. And I'm like, I feel like publishing papers might be more value to you guys than my
Mhm.
saying I took the same kind of uh uh test that you took, I guess. That's my
Yeah,
opinion. I mean, I don't know.
yeah.
Is that Mary's voice?
Yep.
Like we had a really good meeting with like Langston Cowgill and Sarah, who is the other person that's kind of like in charge of helping to get this affiliate pathway started up. But like it does seem like it's going to be a lot of work for a pathologist to say that I'm an affiliate member, and I'm also like, well, pathologists could do other stuff with their time. So I don't know. It's going to be difficult. As we're kind of joining, uh, Steph and I are gossiping. I can see JD is on here as well. I do want to recognize that I think this is the first time that I'm aware that we have people who are now considered board certified nephrourologists. They have passed their boards exam. JD is one of them. I can see him. Hattie is one of them as well. And if I miss your name, it's because I'm not seeing everybody that's popping up. We have future people who will be taking the tests soon or in a few moments or in a few years, a few moments, in a few years, pop quiz. Let's all welcome our very first board certified people. as soon as they get their case logs in, Dr. Skinner, um, so that we can say that we have people now who are um, I guess legally recognized as being experts in, I mean, I don't know what there's probably a better word of saying it, but people have sat boards and they have passed boards. And the boards I hear were not easy. I hear that they were very difficult. So it's an amazing first step in the college. Um, and we will have more and more people as they get boarded use the biopsy service and the urinary service as their submission forum, I guess, for submitting samples. And then hopefully these rounds will get a little bit broader. I have kind of changed the title so that it is clear that it will also have urinary samples. Oh, hi, Dr. Jepson. I can see your face. So anyway, so this will be a little bit broader around like this particular case that we're going to talk about. We have two cases lined up. They are lower urinary tract. And so so yeah, let's everybody congratulate those people who've become board certified. Also, I guess it's a good time because I see Shannon's on here and Haley is on here. If you guys wouldn't mind, I know you might be traveling, you might be in a car because I know Shannon has stuff she had to do. She's going to judge a science fair. But if you wouldn't mind, maybe showing your face, like Haley showing her face. So sometimes as you submit samples to us, we have these pathologists that will be reading the cases, the tissue portion of the cases as well. So that's Haley Amerman. She actually, you might recognize her name because she worked a lot with the Renal Pathology Atlas, and she was actually one of our students at Ohio State when the laboratory was in Ohio State. And now she is an assistant professor at University of Pennsylvania. And Shannon McLeland is on here. I'm not sure if she can pop on her face, but she is a person that worked very closely with Quimby. We've had a lot of publications together. She's been reading cases for the IVRPS for quite some time. Um, and so we talk extensively with each other. So if there's a case that gets read by them, please know that we've all discussed the case together. And if you ever have any questions, feel free to reach out to any of us. We are trying our best to make nephropathology its own established, well, I guess urinary tract pathology, its own established specialization as well. Housekeeping. Okay, you're fine. Hey, Haley, you can take off your camera and you can read emails if you want at the very beginning. Um, Housekeeping. If you've noticed you have not received an invite and it's been a month, please know that the invites go out every month. So if you haven't received one in 1 month, it's probably a problem with Outlook. And Dr. Hokamp has also put the Texas A&M email address in the chat. I think this is being recorded. But hi Shannon, yay! That was Shannon, that's Shannon McLeland. She's gonna go judge a science fair for small children, so that sounds very complex, and I feel bad for those kids having a PhD board certified pathologist judging your science fair, but good. Um, so anyway, yes, if you haven't received an invite, please reach out to us. It's an Outlook problem. It's not a you problem. It's an us problem, and we will make sure you're added back to the distribution list. And then also, please be willing to discuss a case. Friendship has been very generous in case contribution and case discussion. But we do like a breadth of samples. I'm actually probably trying to take the second case. It is from Colorado Animal Specialty, something like that. It's from Karina and Dan's practice. I'm not sure if they will be here, but if there is a case where it's like, hey, I actually can't attend, but I really would like it discussed, again, reach out to us. We'll find a way to discuss it. And then it will be recorded and you can watch it later. Because I understand these rounds are not easy for everyone to attend, especially the people in Europe or Asia. So if there is a case that you would like us to discuss, but you cannot attend, you can request it. We will discuss it. We will record it. You can watch it later. Any other comments from the IVRPS folks? Pretty good? Okay, I will let Steph start with this, and I'm going to locate the slides as she's discussing this, so I'm going to take myself off video.
Great. Okay, this is going to be very clinically heavy apropos this part. You can see it. Okay. So this is Chuletto. Obviously, he's a very handsome guy. He he came to me in December as a 3-year-old male intact American Bulldog. At the time, the owners had noted a few month history of stranguria, where the episodes always seemed to resolve on their own, but the time in between episodes was getting shorter and shorter. And then on November 24th, he was just unable to urinate completely. And oddly enough, went into the RDVM and they were unable to pass the UCAT. They had to do a decompressive cysto. The RDVM did get some initial diagnostics. His urine had concern for bacteria in it, but they got it off the tabletop. The urine culture they got off of the cysto showed no growth, and they also took some radiographs. And for those who have not seen too many slides with sperm on them, this is the size they're supposed to be. We've had some confusion about what those are supposed to look like in the past here, but just as a reminder, this is his urine sample. And then the radiographs, the initial readout said that there were no stones, and the RDVM actually did a good job because they also got a shot where we can see his proximal os penis, because that's a pretty common place for stones to get stuck, but still confirmed that there are at least no radio opaque stones that we could see. And they recommended that they come through the ER, and the owners did the next day. But when he came in through the ER the next day, he was actually able to void on his own, despite the RDVM being unable to pass a urinary catheter the day before and really not doing anything besides starting him on enrofloxacin while his culture was pending. Our urgent care service did do an ultrasound, and they were concerned for urethritis and cystitis. He's intact. This is the kind of relatively normal looking intact prostate. It wasn't that impressive. And then they also confirmed that they did not see any stones, at least in his bladder or the visible portions of his urethra on his ultrasound. So he went home again and was scheduled to see me for a follow-up the next week, but he came in again through urgent care, unable to urinate just a few days later.
Oh my God,
At
that
that
bow
point,
tie. Look at him.
yes, yes, he is
I
incredibly
know why you
handsome.
wanted to discuss this case now. You just wanted to show how cute he is.
I have so many pictures of this dog. um, so he transferred to us, and at that point, the concern is still he's an intact bulldog. I don't know for the clinicians on the call what other concerns you guys would have had with this dog, just having what we've had up to this point.
Yeah, are there clinicians that would want to be concerned or list their concerns or maybe problem lists for this? Anyone? I see some of the people that are pathologists. Was that you, Dr. Stein or Dr. Jepson?
Oh,
I know the
they're all
dog
being
didn't
too
have
shy.
any stones, but I would have pegged him for a cystine stone former. Obviously we didn't see that on imaging, so more concerned for something functional.
Yeah, and actually, I was still a little bit worried for cystine stones because sometimes they are hard to see on rad. So I was not 100% convinced his urethra was totally clear of stones, even with his rads looking relatively unimpressive.
Fair point.
Um, but but yeah, so otherwise he had no history of stones. Like the owners had never noted that being an issue for him before. Um, and certainly from a functional perspective, the only thing that was a little bit odd for that was that his signs were either peeing or not peeing. He didn't have the more classic dribbling or slowing of urine stream. He is obviously a low rider, which you guys might not quite appreciate from this this picture, but so there's a little bit of a question of I never 100% trust what an owner says, but yeah, so we uh we said let's look at his urinary system a little bit more, and we started the cystoscopy. For anyone who gets car sick, you might want to close your eyes for a second. This is a little bit shaky, but this is his cystoscopy. And to give you a sense of orientation, dorsal is at 5 o'clock and ventral is like 10. And this is his proximal Oz, and it is not normal that the scope does not fit. He's a large intact dog. He should have a massive urethra, and we should be able to get through this very easily. And here's just a still. This is very abnormal, but also was a little bit confusing because it seemed more like an extramural compression than necessarily intramural. This kind of inflamed looking tissue you can see around 10 o'clock was almost certainly both from the scope itself and the prior urinary catheter passage attempts. We did not biopsy because shortly after taking the fluoroscopy, all of the power to the OR went out, and so the procedure was done for the day. But we did get this fluoroscopic image, interestingly. So he has a very constrictive lesion at his proximal Oz. This should be a nice, smooth column of contrast, and it is very much not in his case. And we ended up doing bougonnage with dilators, and this is better. It's a little bit smoother. It's certainly still not normal. But it certainly seemed like this was the cause of his inability to urinate, is that, this is where there was the concern for a possible extramural lesion. We did place a red rubber, and then I went back and had our radiologist look at his rads again. And what she had noticed, which I had not, was that on those initial rads, there was this concern for possibly him having a lytic lesion in his proximal Oz. She ultrasounded him. So this is a transverse view of the proximal Oz, and he should have just like a nice, smooth, single looking lumen in here that is like the soft tissue under the bone, but he's got these kind of funny cystic lesions that the ultrasonographer was able to aspirate, and unsurprisingly, we got a non-diagnostic sample, just blood in it. So that's fine. We placed a temporary red rubber. I said, I don't know exactly what's causing this, but let's like buy some time to keep him peeing and out of the hospital and figure out what's next. And then we got this picture from the owner later that day. For those of you who don't place a lot of red rubbers, you're not supposed to be able to see multiple parts of it sticking out. So he came back in. We replaced it. Weirdly enough, I had to re-bougie him, even though it was 24 hours later. And I've also never had a dog get the red rubber out in this particular manner. So I was a little bit impressed. And then 24 hours after that, so 48 hours after the initial procedure, the owner emailed us because he said that there was a lot of bruising, and he came in looking like this. So obviously we were pretty concerned about what was going on with his Oz at this point, what was going on with those lesions. He was very painful. He was trying to bite people, which was like a little bit of a biter, but not that bad. And we were still like his catheter, even though it was in place and we confirmed that it was past the Oz and up into like his perineal region, he actually was obstructed again. Like he was compressing the red rubber catheter with whatever was going on. So at that point, we talked with our surgeons and talked with the owner, and it was a big long conversation. But we ultimately ended up removing everything. He got a phalectomy, a scrotal urothrostomy, a neuter, a scrotal ablation. His lymph nodes were removed. We essentially said, I don't know if this is benign or malignant, but if we want to keep him peeing and out of the hospital, we should get rid of the obstructed area. And this is the best way to figure out what's going on, because we were not sure that a biopsy was going to, like a punch biopsy or something, or like an excisional biopsy was going to get us an answer, and that this was the best way to see what's going to happen. And then at first there was some confusion about what was going on here. Ray actually sent this picture to Rachel. This incision was from the surgeons because the Oz and like the mineralized part of it just went a lot farther back than they expected. That I don't know that he's done that many phalectomies, but he just said, yeah, it was just a lot of tissue that was very calcified. So that's everything that we ended up sending. And I think that is what I have for now. Oh, and then 1 week post-op, just for anyone who is wondering, honestly, from the side, he still looks like he was just neutered at a young age because his little like umbilicus sticks down a little bit. But he is smooth like a Ken doll, peeing great, has not been back to the hospital. And then we were just waiting for what Rachel told us about how worried to be with that penis.
So, yeah, so the I guess I will do a caveat here. We are a pathology service. We focus on core biopsies, needle core biopsies. And when they said we were sending us everything, and I knew we were getting an os penis, I was like, well, we're gonna have to decalcify it, and it's not something that we have readily on hand in our laboratory. So they were able, obviously, it's part of Texas A&M. There's a pathology service at Texas A&M, and they were able to get the ability to get the sections and um, so the decalcification process, and I guess this is good for clinicians to know. So you can either, let's say you have like a femur that you need to decalcify, so that you can cut it to see, to diagnose tumor or fracture or whatever. Usually that's submersion or immersion, submersion, I guess, decalcification. And so you put it into a special solution, you keep it in there for like 24 to 48 hours. And then that removes the calcium part of the bone. And so now just the matrix remains. And so then once you take the bone out of the decalcifying solution, you can bandsaw it. So normally it would be very difficult to bandsaw a bone because it's so mineralized. But it makes it not even bandsaw. I mean, sometimes you would bandsaw it even without decalcifying, but you can cut into it with like a scalpel. So now you have your big bone that no longer has calcium, and you can make your very small slice with your scalpel, and that's post decalcification. Another route you can do is if the bone is small enough, or maybe the calcification process is not severe, you can go ahead and cut it into a tissue block, put it into paraffin, and then process it. And then you take the paraffin block and you do a surface decalcification. So you take the paraffin block and you just put the solution kind of on the top and you let it permeate into the tissue and it takes out the mineral. And so now once it goes on to the histo, the micro, the to be cut micro for the microscope slide, um, it can actually, the blade can actually cut through the paraffin block and the tissue. Sometimes you have to do both, especially when you're thinking about large bones. You would probably have to do an immersion decalcification and then a surface decal. For this particular, I know this is a lot of information, but I think it was something that pathologists kind of just throw around. Also, we don't do it. We have the lab do it for us. So it is something like terminology that we throw around, but is a little bit not familiar for clinicians. So this particular case, the portion of the os penis where it was cut, um, was able to be cut through and then embedded, and then they did surface decalcifications um, on the top sample of the block. And it's a different Haley, but there is a second Haley who helped with that. She is a pathologist, and now she's doing her PhD with Dr. Hokamp and Dr. Nabity. And so she's going to be doing a lot of hopefully lower urinary tract stuff for us. So anyway, so we got the samples. I have the slides, but of course I pulled up a different slide. Just a moment. Okay, that's still there. And I'm going to share my screen in just a moment. Okay. Share my screen. Hopefully you guys are seeing a cross section of tissue, H&E
Yep.
stained. Okay, cool. Okay, so this is where Rachel does says she'll look at things, but sometimes she doesn't always know what she's looking at. I can tell you that everything I looked at, Steph, you're getting really like you're kind of giving me a lot of pressure with this little like maybe turn off your camera, don't freak me out. Okay, so we have a cross section of the tissue here. We have multiple cross sections through the length of the os penis, and we actually took sections that were kind of right next to that incision that Steph had originally showed us a picture of. Um, but normally you would see a tube of connective tissue, you would see bone, and it's just the one region kind of underneath the urethra. I'm saying that correctly, I hope so. And then you would have a lumen, a urethral lumen that's lined by urothelial cells. And so because the original sections were actually very difficult to cut through, and we did more decalcification, and so we got better sections, and this is one of the semi-better sections. But we truly do have osteoid in here, and There is a lot of kind of fibrous connective tissue in between the bundles of osteoid. And then you have a few regions with a little bit of fibrin and inflammation and granulation tissue, kind of within, in between the spicules of the osseous tissue. And so when a pathologist is looking at bone, and that's not my area of expertise, but when we're looking and trying to diagnose something like osteosarcoma or maybe chondrosarcoma, which osteosarcoma has been reported in the os penis, um, there is a specific way that bone looks neoplastic or osteoid looks neoplastic. And I will have to say, it is smaller amounts of this dense eosinophilic material. The lacunae with the osteocytes in them might be more haphazardly arranged. The nuclei that are within these areas might have more atypia, they might have mitoses. You would also see a lot of cellularity kind of outside of the osteoid tendrils or trabecula, I guess is the best way to say it. So there is a way that we look at bone and say, hey, that looks like it's neoplastic. And I am not great at describing all of those features because that's not my area of expertise. But everywhere I look in these areas of bone has like pretty normal nuclei with inside of lacuna. Um, and we did have a few fragments that were acellular. Oh, I just did that. There were like acellular bone fragments. So, where, and I'm not going to be able to find them immediately, but a few tiny little pieces of osteoid that had lost their nuclei. So the nuclei are probably have died, the cells have died and disappeared. And so there's when you see tiny little bits of fragments like that, they are kind of suggestive that there's been trauma in this area and that there have been microfractures. Um, Sometimes if they persist for long periods of time, then we'll even call them like kind of little bony sequestra. And I'm gonna, it's probably not even on this particular image, but the other thing that's kind of striking right here is here's another area that's probably a vessel that has fibrinoid change of its wall, a little bit of hemorrhage. And so you do see a little bit of hemorrhage, a little bit of granulation tissue, a little bit of vascular change in these areas. And then the large region of hemorrhage, kind of in a luminal aspect. This is probably subacute. You can still see this yellow color, which shows that that's probably hematoidin. So that's usually like kind of more recent hemorrhage. It didn't happen years ago. It didn't happen weeks ago. It probably happened a few days ago. And so this is probably the source of all the bruising that Dr. Skinner showed us on the photograph. And here's more hematoid and more hemorrhage within the soft tissue. And we all looked at this. Dr. Amerman also looked at it. I'm going to see if there's another picture. Let's see. This area I think is past the os penis, and we truly, oh no, no, we still have some we have some dense connective tissue here. So this might be kind of like right at the edge. But we do finally have a urethral opening with urothelium. The urothelium looks great. I do not see any evidence of an invasive urothelial process, so that's helpful. It helps us rule out that there's probably not an invasive UC urothelial carcinoma hanging out here. And then there should be one more picture. Here is another region. I did, Dr. Skinner, I do want to say that I when I went back and saw where each section was taken from the gross photo, I did annotate it a little bit better in the database we have, so it's clear like this one came from the proximal portion or whatever. Um, Here we have a little bit, so these are like the osteoblasts that are probably making a little bit more new bone. So they should be there. They should be kind of like, usually slightly attenuated, maybe a little bit cuboidal if they're doing some remodeling, which this part is. Again, we have a lot of hemorrhage in the stroma And this, I wasn't really entirely sure what to make of this material. This looks like adipocytes that are kind of undergoing, we sometimes we use the word serous atrophy. We can sometimes see that in bone, like medullary medulla of the bone and like the femur, and we call it serous atrophy of fat. So usually something has happened and we're kind of degenerating and changing. It's actually like more of a gross term, but you're changing the fat when you split open a bone section and it looks a little bit more gelatinous and kind of hazy blue. That's kind of happening here. I don't know what would be causing it because it would be weird to have to like need your fat reserves in this particular location. But I do think that something is kind of changing these adipocytes to have more matrix in between them. And any pathologist who would like to speak up and tell me I'm very wrong about my assessment of bone, I'm very happy to listen to you. Um, Dr. Amerman, do you have any other? Oh, we also got lymph node from these, and there was no evidence of any kind of metastatic disease in the lymph node. That's the other case for later. Uh, Dr. Amerman, did you have any other kind of areas that you were interested in?
No, I was just gonna say, I know you mentioned this, Rachel, but Steph, I took a look at these slides too, because it's just a, yeah, weird case, weird processing, weird sample, all of the above. So, I spent a long time looking at these slides too, and I agree with everything Rachel said. Like everything that I was seeing here, all this like chronic blood breakdown, product deposition, weird big like pools of blood, stuff like that, and then all of these bony changes to my eye were all just reactive. And it is, I mean, it's weird, right? Like I obviously contract with the IVRPS, but most of what I do is just read a multitude of surgical biopsies. So I do look at injured, damaged bone, whatever, with some frequency in just like my regular autopsy, or sorry, well, autopsy too, but also biopsy caseload. And these are all things that like I associate with trauma. So like it's just, I don't know, like it's weird, but I agree with everything that Rachel has said. It's just a funny sort of location, I guess.
Yeah, and I think like part of it is there's no evidence that the bone itself is neoplastic. I mean, he's a young dog, so that's also a little bit helpful of us to say like it's would be really unexpected for him to have an osteosarcoma of the os pinus. I think I've diagnosed that like once in the past. But I probably also had really good imaging and like I was probably on autopsy. Like I do remember having diagnosed it once. But the osteoid here, the trabecula are too thick, the osteocytes are too organized. They don't have any evidence of atypia. Even in the stroma, where that would be another place where osteosarcoma cells would exist, they would hang out in the fibrostroma as well. They would have atypia, they would have mitotic figures, they would have multinucleation perhaps, they would have large prominent nucleoli, and none of the stromal tissue is having that either. I actually don't even know what was the final bottom line. I can look and see what the bottom line for the diagnosis was, unless you have the report and rate in front of you. Does anybody else have any more questions before I close these histology images?
There's just a comment by Becca Mackey
Mhm.
about it being not screaming osteosarc and more consistent with trauma.
Yay, and I know Becca has done a lot of PhD research in osteosarcoma bones because I saw her amazing presentation at ACVP. So yeah, we would not put this into your spatial transcriptomic stuff because this does not look like uh, a osteosarcoma bone. Um, the comment or the questions that we had for staff as we were still writing this up was, is there a history of external trauma? It did seem like this dog kind of just developed this, and could some of this trauma be from the procedures that were happening, like the bourgeonnage and the placement of the red ripple catheter in complex with the fact that this dog was straining to urinate and causing some kind of like almost like iatrogenic or its own kind of microfractures. And that, do you think that's a possibility, Dr. Skinner?
I don't like timeline wise, it was like maybe 72 hours between the first bousionage and taking off his penis. I don't know if that's like a long enough time period for some of these changes.
How long had he been straining?
He had a few month history, probably like 6 months of the intermittent straining, which
Okay.
like it was so bizarre because like the owner said he would not be able to urinate acutely and then would go back to urinating normally for initially months, then weeks, and then obviously he like obstructed and came in to see
Oh
us.
yeah,
But
because you said it was like even though he could start to urinate again, like the periods between the strange jerk episodes were shortening and shortening.
yeah, and
Okay.
he certainly had no bruising prior to me messing with him. And I have lots of pictures of his belly. um, but there was like no bruising beforehand. Certainly there was like no concern for trauma anywhere else. He was definitely a very loved indoor dog. There was like no history of breeding, or anything like that. So very, very odd. Also feels like he has like beefy thighs, and that was like that was part of his Oz was like well encapsulated by muscle on either side. So it feels like maybe a strange place for him to fracture, like just that part of his Oz, but I'm not sure. It was also like kind of funny how it like looked maybe a little bit lytic, but not necessarily fractured. Not that I look at like bones on radiographs that often, but
Yeah, I just
brought him
wanted
to
to
us
show
for it.
you the photos because I was having trouble locating this part again. This was in that area that I was showing you with the big hematoma. And I think I bottom line this as a large hematoma superimposed on chronic bony reactive changes. But I just want to show you what we kind of see when we see these kind of like little areas of osteoid. So here was the osteoid kind of like that I was showing you before that truly had lacuna. Hopefully you guys are seeing the little arrow cursor. And a little bit of granulation tissue. And actually, like the today I found even better vascular damage with that kind of fibrinoid change of that one vessel. However, there were these small folks. These are small. Like these are not like they're probably a couple microns maybe. So these are small, tiny little microfractures. This isn't a huge, fracture line. But you would start to see every so often embedded in the matrix these areas, which are the same color as osteoid. And then when you go to higher magnification, you can see that the lacuna are empty, or they have, little apoptotic nuclei or little kind of degenerate nuclei inside their thing. And they also have this kind of hazy blue change along the kind of following along the surface. And sometimes we'll see these things as it's like almost a line of mineralization. Um, so obviously osteocytes are very active and they're always putting in calcium and they're always modifying the amount of matrix and the type of matrix and the mineralization components of the matrix. And so these little kind of we call them bony reversion lines or resorption lines, Haley. I can't remember which. We call them something.
I
But these little
often
lines are very
use both because I don't know which is which.
okay. Good, good. So this is evidence that that something happened to this area of osteoid, and the cells were trying to repair it and trying to modify the matrix, but now the cells are no longer there. So
Is that
and these
like
kind of are
a month?
embedded in,
That's like a month timeline or like weeks or days? Like what?
probably weeks to months. It depends on how, like, I guess I'm saying, and please correct me if I'm wrong, or if anybody other pathologists that look at bone more often. I mean, you can technically have sequestra that, like, from what if there was a microfracture or trauma that happened months previously and nobody really noticed it, and these little tiny little bits, like these little shards kind of came off and got embedded in the matrix. Um, they're just going to sit there, right? Like the cells are going to die, and like it's really hard to resorb all of that with scar tissue and try to get rid of that matrix. And so they could just be sitting there making continual microtraumas and more granulation tissue that's surrounding it. I saw there was a comment in the chat. Does anybody else? Does he like to mount things? We had this happen again in a pity who liked to mount a sweater in the house.
The I I did not the owners did not volunteer if he was a big humper. No. But I could ask them a little bit more specifically about that.
Okay.
And I
Also,
just
as
wanted
we're kind of
to
Go
Oh,
ahead.
sorry. I was just gonna say, just to chime in really quickly about the bone too. Um, the sort of the lacunae losing their osteocytes, that particular change, just for reference, like Rachel said, can take weeks, sometimes up to months. So like just like it's sometimes I think thought by residents or maybe like early trained pathologists and stuff that that's an acute change, like, oh, lacunae don't have their osteocytes, like this bone died a couple days ago, but it takes in reality probably more like weeks for that change to actually be visible underneath the microscope. So like looking at that picture that Rachel has highlighted, this probably happened like weeks ago or maybe months. It's been around for a while.
I agree, and I think that the hematoma, the more recent hematoma was recent, right? I mean, that makes
It'll
sense
probably be,
with
Yeah.
the
yeah.
history, but something was always abnormal with this bone, and that might be the area that was kind of lytic on the edge. So we can't really say what happened, but there's histologic evidence that trauma, small fractures happened previously. And I would guess weeks to months for this pathway or for this pathogenesis. And then all the other stuff compounded, right? He continued to strain, he continued to put pressure on it, and it was, you know, the most proximal portion as he's like trying his hardest to urinate. And now it's almost like a vicious cycle.
And Sarah, what
Um,
did your kitty end up presenting for? Like difficulty urinating, or they were
Yeah,
worried he'd broken
can
his
you
os?
yeah,
we
can
can
you
hear
hear
you.
me okay? Okay, yeah.
Yep.
Um just choked on my water. Sorry. Yeah, very similar. So was basically came in through our ER like two or three times for straining urination, not being able to urinate. They passed a catheter relatively easily, and then we didn't see any stones. Kind of similarly, the third time he came in through medicine, and then we noticed the change on his os penis. So, you know, we were really concerned about neoplasia, and then basically did a cystoscopy, very narrowed at the os penis, and then we just never could get him to urinate, and the owner just kind of wanted to be done with it. So we removed the whole structure as well, and it all just looked like trauma associated. And once we talked more and more with the owner, they said he had occasionally mounted some things, but they put a night camera on and he was pulling out sweaters and having a rendezvous in the evenings that they didn't really know about. So we think that's probably what had been happening. So, yeah.
That
I will.
is so yeah, so this isn't, I mean, we have a case series now. We got two, right? As and I do want to transition to the other case just so that we can look at the histology because that is impressive and it is something that I do know a lot about. But I do want to say that so also I think I've had a regular biopsy through Zoetis where I didn't know it was a thing. I had to text JD about it, but bulldogs, English bulldogs themselves, mostly English bulldogs, I think, is what's in the literature, but they can have such straining that they have urethral prolapse in the males. And I guess it's something that people know about. Is that true? Steph
Yeah,
might have
English
frozen.
bulldogs and French bulldogs are certainly the most common ones that we can see, but generally they're puppies, they're young, growing males, but
Oh,
bulldogs are probably the worst that can happen at any age.
and so you basically just see a little bit of urethral mucosa pop out, or is it bad?
Well, it's not a ton of tissue. It's probably just a couple millimeters of tissue that comes out, but it does then get very congested because
And
as it
inflamed, and it's hard to
pivots
get back.
the yeah the venous blood can't return, so they'll often have like this purplish pea appearing thing at the end of their urethra, and it's irritating. They want to chew and look at it. It's uncomfortable, so it's yeah, it's a pain. You can reduce them manually, but in particularly in bulldogs, they'll generally come back, and they usually need to have them surgically removed and have their urethra kind of just the mucosa resected and then resutured to the
Okay.
end of the penis.
Yeah. So thank you. That's also like I just got a regular sample of urethra. It looked really congested and inflamed, and it was like something about they did write sticking out of penis. And I was like, well, so I texted JD and I found there was a paper about it. So there are a lot of things that I to this day I'm still learning. But there's got to be something weird about. I mean, I know is this a staff? What kind of bulldog is this guy? Is Chilito American pit bull or something? Can you tell I'm not a practicing clinician because I don't know my breeds?
Giulietto was a bulldog, was an American bulldog, yeah.
Okay. American versus
American.
English versus French. Okay, I'm going to show one more quick case. It's going to be impressive. Just because of the cellularity, so I'm going to close these files really quick. And then I do need to get the history out. This is a case that came from the oncology service in Colorado at Colorado ACE. I don't know what the ASE stands for. But uh this is a dog that we are actually getting more tissue from because I think the tissue was sent elsewhere. I think it was sent to Colorado State, so I think Colorado State's sending a test to us for the whole mass because they removed a little bit of tissue with cystoscopy that they sent to us, and then they had to remove the entire urine mass from the animal, and I think it accidentally got sent to Colorado State, and so Colorado State is sending us the recuts. But I'm going to give you the signalment. This is a female spayed lab retriever mix. She's 9 years old, and she had a bladder mass. Had in ultrasound. They had an ultrasound done, and the ultrasound was performed because there was hematuria. And they found the mass. They also found some other things like a hepatic mass and a pulmonary change as well. So I think they removed a little bit of other tissue, and that's part of the reason it got sent to Colorado State. But I do have the pictures open. So all I got was the cystoscopy sample, and I'm going to share the pictures with you because they are impressive. So as people that are reading more cases with us and sending us more urinary samples, um, uh, and I get a lot of urinary samples through my day job, which is my zoetis job. Some of this stuff we know and we're kind of getting, that's not what I meant to, more familiar with about cystoscopy samples is a lot of times they're kind of crushed. And that makes sense. I mean, you're going in there, you're snapping. It's like almost like getting an endoscopy sample. They're going to be crushed. But it's hopeful. We are hopeful that we will get a sample at least like this, where we have our urothelium, which is at the top, and then we at least have some amount of stroma that's supporting the urothelium. And that's very helpful because one of the features we like to look for is invasion past the regular junction between the urethral mucosa and the stroma. Now, it can be somewhat difficult, and Haley Dodson, who is the new PhD student, I hope that we're going to figure out a better way to characterize this stuff because sometimes these masses are actually polyps and they're sticking into the lumen. And so, trying to figure out is it the stroma of the polyp that has the little invagination of tissue, or is it true lamina propria underlying the urinary bladder that is being invaded? And so, that can be difficult. But I do want everyone that's on here to look and see that we have urothelial mucosa. We have enormous nuclei. This is probably two nuclei within one cell. They have these really weird, large nucleoli. This particular cell over here has probably four nucleoli. And there were a lot of mitotic figures, or maybe not the highest mitotic rate, but a lot of the mitotic figures were abnormal in shape. This guy over here is probably undergoing apoptosis, or maybe he was a macrophage that is eating up a dying cell. It's really kind of hard to say what's going on. But get the impression that these urothelial cells are severely atypical. Again, seeing all of these irregular nuclei and nucleoli, and these guys here are dying cells. This is definitely an apoptotic cell. So the urothelial population being abnormal is one of the characteristics for urothelial carcinoma. But then when we try to grade it, we're looking for infiltration past the basement membrane and into the stroma. And I think we have two pieces. this piece was a little bit, oh, this piece actually had smooth muscle, so that's good. If we had invasion into here, we would have a knock like a definitive diagnosis of urothelial carcinoma. They don't always invade the smooth muscle. Sometimes they just invade the lamina propria. But this guy was the better part. So uh trying to identify like this one island, I think this is evidence of infiltration, and I think we have basement membrane between the urothelium and the underlying stroma. It would be great if we could have a better way of proving that there is basement membrane here, but there's not basement membrane around here. And so even a PAS on doing on some of these samples that we have and characterizing the thickness of this basement membrane, sometimes you don't actually see it very easily, and it can just be this like thin strand of collagen. But a lot of times, especially in like the inflammatory polyps, it gets really thickened and hyalinized. Anyway, it was a very impressive cellular atypia, but minimally invasive urothelial carcinoma. The samples that went to Colorado State had the same nuclear atypia and same kind of high mitotic rate or similar mitotic rate. She did not see definitive evidence of infiltration, but I'm just wondering if these tiny little foci might be present. And so they're going to send us the whole sample for us to evaluate, or I guess recuts of the whole sample to evaluate. Do any pathologists or clinicians have any comments or questions about this case? Um, as we're kind of getting to that point where, hold on, what did I do now? I'm going to stop share. It would be great to have Um, a little bit more consistent criteria for the grading system, and that's kind of what I'm plugging here for maybe Dr. Dodson's future project. Right now, the grading system that exists is somewhat taken from the human pathology literature, and one of the main differentiating criteria between low and high grade, which I actually agree with this criteria, is presence of invasion. So invasion past the urothelial basement membrane and into the stroma or into the lamina propria. Now, the problem and the complicating factor with this is that there is an inflammatory process where little bits of urothelium will kind of impinge into the stroma. And they are still supposed to be surrounded by basement membrane. And those are called von Brunn's nests, if any of you guys have ever had that term used in a pathology report. So technically, those things are just hyperplastic foci that kind of like bulge down into the stroma, but they should still be surrounded by base membrane. That being said, like I said, sometimes it's hard to see the basement membrane. So if we need to do special stains to highlight the basement membrane, that might be part of the project that we're going to have to do. Or also the comment of, well, if it's just going into the stroma of a polypoid structure, is that big of a deal? Is it more important that it's going down below the stroma of the polyp and into the lamina propria? And so that might be something we have to consider as well when we're trying to update, I think, the grading system. And so I think what we'll probably end up doing is obviously we have a lot of cases we've collected through the IVRPS. I have a lot of biopsies I look at Zoetis, and trying to get some kind of follow-up to better write criteria, especially for these cystoscopic specimens, where I'm like, is this just pinched lamina propria or is this stroma from a polyp and they removed a polyp? And so um, those are probably going to be things that maybe are going to come as questions to you guys when you guys submit samples. Like, was this a polypoid mass or was this kind of a flat sessile lesion? So we might have to maybe add a couple check boxes on the submission form. Yes, you also have a lot of biopsy cases at Texas A&M that we can include as well. And if we want to go real big, we can get those samples from Penn because there's a boatload of those at Penn as well. So. Um, does anybody have any comments or questions or what, I guess, maybe thoughts that you guys, once you see the pathology report for urothelial carcinoma, do you guys pay attention to the grade that we're using if we're using kind of an old grading system? Do you even care that we grade it for you? Do you just want us to use the term invasive so you know that we have definitive evidence of invasion? What would you guys like as clinicians at this point? It sounds like everybody seems like just to read it and they just move on with their treatment. Once they know it's urothelial carcinoma, they treat all of them the same or what?
Send
At
them all
least,
to the oncology service.
right. I mean, I was gonna say, at least at CSU, we have like 3 clinical trials for this, and at least when we've talked about it, whether it's invasive or not, we don't tend to talk about because it's such an aggressive cancer, but I don't think that's really been looked at.
Okay. Yeah, I mean the literature is kind of like this, like there's even a more recent review paper, I think it was like in 23, that was like, hey, this is the change in the grading systems and how they've changed. And the main part of it was like, if it's invasive, we're going to call it high grade. Um, but then the cellular characteristics, the cellular nuclear atypia, that's supposed to be for a grade 4. So like you basically have grade 1 and 2 that's low grade and grade 3 and 4 that are high grade. And but again, is the cellular atypia and mitotic count, is that predictive in and of itself? Like this particular case that I just showed you, which is crazy cells all over the surface, um, but not necessarily infiltrative. In my opinion, this would be one of those types of tumors that could detach from the surface and then surface implant elsewhere in the bladder, so that even removal of the sample and the main mass doesn't mean that you're going to miss tiny little micrometastatic things that from tumor cells that are on the surface floating around in the urine and then attaching elsewhere. Um, but we don't know that. We haven't followed any of these up. So, it does sound like Texas A&M doesn't even grade. And I basically just started using, the grade that was recommended in the paper just to be consistent. But if nobody is using it and people just want to know it's urothelial carcinoma or not, and then having the word infiltration, that gives you at least a little bit of information, then maybe that's how we kind of reframe the grading system. So I guess TBD, but I did want to show you an example of a case where the cells were crazy. That was just a little bit of dog fur. The cells were crazy, but we really don't have, at least in the small pinch sample we have, don't have evidence of infiltration deeper into the bladder wall. Okay, looks like we ended up kind of okay, so we have comments saying that Texas A&M doesn't really grade, Penn doesn't really grade, but they have a lot of samples. They have a lot of cats with UC. Yes, the cats are interesting as well. So cats with UC, I diagnose that less commonly, but I will say what's interesting. I just looked at a case yesterday, and I texted Hocamp about it through my regular job. Um, Cats with UC don't have, and actually this case didn't really have a lot of them either, but there's these like kind of proteinaceous inclusions in a lot of urothelial cells that we call Malamud Walensky bodies. That's really common in dog urothelium, normal urothelium, but also in urothelial carcinoma. And cats don't really make those. So there was a case where there wasn't a species listed, I think, because the veterinarian that submitted it didn't really do their job. It's from a regular general practitioner. And so I looked at it and I was like, oh, this is obviously a cat urinary bladder urothelial carcinoma. And I called and confirmed, but I could tell based on the cellularity, it was truly a urothelial carcinoma, and it definitely had invasion, but it was the urothelial cells themselves were distinctly different than what I see in dogs. So yes, I do think that um, uh, it would be nice to have a grading system that has prognostic value. I do agree urothelial carcinoma is an aggressive tumor, and a lot of them have already metastasized, or will metastasize or will spread, but we need better follow-up data and not just to use the proposed system that exists because that's what's been used in the past. Um, okay, questions. That's awesome. That's great. And this is being recorded, so all these comments will come out in the conversation and the transcripts, I think. So we can go back to these questions or these comments, but it does sound like people would appreciate more prognostic information if it were available, but that the pathologists really need to work on our side to make sure that the information we're providing is relevant. Um, okay, so we are at the end of time. We do have let's see what time, when our next session would be. It will be February 1, 2, 3, the 17th. Um, please look for an invite at the beginning of February, and we will reconvene for another set of sessions of urinary pathology rounds. Thanks, guys. Thanks, Steph, for presenting. I appreciate it.
Thank you, Rachel. FYI, you have gotten at least one email about adding someone to the email to the
Okay.
chain. So just as
Cool.
an FYI.
Cool. Okay, sounds great. Talk to you guys.
Bye.
Bye.